Welcome to Podcast UK.
Hello and welcome to this Cappuccino break episode. I'm Aisha Chaudry, a core surgical trainee in Yorkshire, and today I'm joined by Matt Stone, a plastic surgery registrar in Yorkshire, and of course co-founder of Podplast UK. We'll be talking about Breast Implant Associated Anaplastic Large Cell Lymphoma, or also known as BIA-ALCL. It's rare, but it's something every plastic surgeon needs to understand, and it's a key part of the consent process for any patient considering breast implants. Thanks for coming on, Matt. So let's dive straight in. Please, can you tell us what BIA-ALCL is?
So ALCL is a rare hematological malignancy. It's a T-cell non-Hodgkin lymphoma specifically. And BIA-ALCL is a rare variant of this, associated with the use of breast implants. It was first described in 1997 and formally recognised as a condition in 2016 by the World Health Organization. It is important to make clear it isn't a type of breast cancer and it doesn't arise within the breast parenchyma. Now, cases have been reported across a wide range of implant manufacturers and with both silicone and saline implants. The exact causes are poorly understood, but it's believed that the texturing of the implants plays a significant role. Although cases have been reported in patients who had smooth implants, on further investigation, most were found to have had previous textured implants or had missing data from their implant history. Therefore, to date, there are no confirmed cases in patients with a history of exclusively smooth implants. In 2017, Dr. Anand Deva's group carried out a study in Australia and New Zealand and found that there was increasing risk of ALCL, which correlated with the increased implant surface area. That is to say that risk was increased in macro-textured implants compared to micro-textured implants. In particular, Allergan BIA-ALCL implants were found to have a slightly higher incidence and were subsequently voluntarily withdrawn from sale in 2019.
That's really interesting. So it's a type of lymphoma rather than breast cancer itself. Do we know about the pathophysiology that causes this?
Well, there are theories that it may be occurring due to chronic low-grade inflammation from a sustained T-cell response to bacterial antigens within biofilm, and some studies have shown differences in the microbiomes of capsules in patients with ALCL compared to those without who had capsular contractures. But the causality of this remains unproven. There is some evidence that textured implants may be associated with more biofilm formation, and there are also theories that texturing of implants may cause microtrauma within the capsule, contributing to chronic inflammation and local immune activation, and ultimately dysregulation. Some patients have been found to display mutations in the JAK-STAT3 pathways, and inherited immunogenetic factors may also play a role, but crucially, we don't fully understand the complex pathophysiology involved.
Right, I see. So there's a lot we still don't fully understand. So let's talk about how often this actually happens. Is it something we should be actively worried about, or more a risk to be aware of?
So it's important to emphasise that this is a rare condition. Worldwide, approximately 1,300 cases have been identified. And in the UK, the MHRA collects data on this. And as of the last published figures in December 2023, there have been just 81 cases reported from procedures performed in the UK. And that equates to an approximate per implant risk of one case per 16,500 implants sold in the UK. But obviously this risk may vary depending on specific implants used. And it's important to emphasise that there has never been a confirmed case worldwide in a patient who has exclusively had smooth implants.
Got it. So it's rare but not negligible. So what features may make you suspect BIA-ALCL?
So the typical presentation is with a seroma within the capsule around an implant, most commonly several years, on average around 8 years, after their primary surgery. Most commonly it's unilateral, but there have been a small number of cases which have been bilateral. As a result, patients may notice a swelling or increase in the size of their breast, which is often painless, particularly in earlier cases. Rarely, it may be associated with a focal mass or localized capsular thickening. Of course, there are a large number of potential differential diagnoses to consider for this presentation, including infection, implant rupture, and malignancy within the breast itself, all of which are much more common than ALCL. In very advanced cases, patients may also have evidence of axillary lymphadenopathy.
What's the next step in investigating it, and how do you confirm the diagnosis?
So diagnosis usually begins with an ultrasound of the implants in conjunction with aspiration of seroma fluid for cytological testing. Ultrasound may show some changes within the capsule, such as localized thickening, but commonly this is entirely normal. You may sometimes see debris within the seroma on the ultrasound, however. Cytological testing of the fluid is conducted, as well as immunohistochemistry, looking for positive expression of the marker CD30, as well as being negative for anaplastic lymphoma kinase, ALK, which helps to differentiate from non-implant associated ALCL. It is vital to make clear in the request that you are concerned about BIA-ALCL so that appropriate testing is performed. It also has distinct cell morphology with a high degree of atypia, large cells, irregular nuclei, and eosinophilic cytoplasm. For negative samples where a suspicion remains, repeat testing and MRI may be helpful. However, some studies have suggested the highest accuracy from the initial fluid aspiration, which is theorized to be due to dilution from seroma reformation in subsequent samples, which increases the false negative rate. Generally speaking, the abnormal cells are confined to the capsule and seroma, and they do not invade beyond this. However, where invasion does occur, there is a risk of lymph node and systemic spread. UK guidelines do recommend that for any patient with confirmed BIA-ALCL, they undergo a PET-CT study to look for regional or systemic spread. If patients have suggestion of lymph node involvement, an open node excision at the same time as any other treatment is recommended, as FNA testing can be inaccurate.
Okay, once the diagnosis is confirmed, how do we then go about managing it?
So certainly any cases need to be discussed in appropriate MDTs, and that means involving both the breast and haematology teams, and ideally those with experience of managing this rare condition. The mainstay of management is surgical. Removal of the implant in conjunction with complete excision of the capsule that has formed around it is all that's required in most cases. Clearly, in unilateral cases, consideration may need to be given as to what should be done about the contralateral implant. For those rare cases where there is invasion beyond the capsule, treatment with chemotherapy may also be recommended. There's also potential roles for monoclonal antibodies, including brentuximab vedotin, which targets CD30, and is being investigated in trial settings for cases of advanced disease.
What is the prognosis like for these patients?
Well, the good news is that generally the prognosis is good for most patients, and it's certainly better than for non-implant associated ALCL. The estimated 5-year survival rate is approximately 89%, and this is much higher in early stage disease. However, it's still a really important complication for patients to be aware of. It's also critical that we report any cases so that we can continue to further develop our understanding, and hopefully in conjunction with robust data supplied to the Breast Implant Registry, this will help us to better understand these rare cases.
Okay, that's reassuring. And for patients who've had treatment, can they still go on to have further reconstruction?
So further reconstruction for these patients after treatment is based on fairly limited evidence, but in most cases patients who wish to can have further reconstruction, usually in a delayed fashion after confirmation of disease clearance and in conjunction with the MDT involvement. This may be achieved either with autologous reconstruction or with the use of smooth implants.
And just before we wrap up, is there anything else we should be aware of?
So there is another similar condition to be aware of called Breast Implant Associated Squamous Cell Carcinoma, or BIA-SCC, which has only really been described over the past couple of years. It's even rarer than BIA-ALCL. There's been around 20 cases reported worldwide, and therefore it's very little data available to try and draw any robust conclusions. However, of the known cases, all presented over 10 years from the initial surgery, and cases have been reported in patients with both saline and silicone implants, as well as textured and smooth implants. Like BIA-ALCL, most cases presented with a late seroma, sometimes in conjunction with pain, localized redness, and capsular contractures. It's definitely something patients and professionals need to be made aware of, and it may be that our understanding improves as further cases come to light. So that was a quick overview of these rare but important conditions, both of which must be considered in any patient presenting with a late periprosthetic seroma after breast implants. I hope that was useful.
Thank you so much, Matt, for that really comprehensive and informative discussion about BIA-ALCL, which may be rare but very important to know about. Thanks to everyone for listening. Hope you found that as useful as I did, and see you next time.
Podplast UK is a collaboration between UK and Irish plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.